The people who've seen this lecture or listened to it, 3 or 4 times, hopefully you guys could actually get up and give it at this point. And that's the aim, is to make things accessible. When we were writing that SST program, there was a real tension between the writers about, we should keep this, we need to provide all the information and make it very scientific and a lot of graphs and things like that. And the reality is our residents have troubles moving from mathematics to real life situations, and you guys see it every day with physicians who are super book smart, but then clinically you're like, what are you doing? And that's because we really lack workable clinical models, right? We focus on the mathematical models and the molecular models, but when you practice with somebody for a long time, you realize they're not doing math in their head. There's some model in there that we don't teach, and often we have a hard time expressing. And so I helped write SST, and then I was in Africa for 3 years teaching there. And you're just forced to teach differently because people are very smart. Our residents spoke 5 languages, but they didn't grow up with math as a background and graphing as second nature. And so you're forced to grab other models. And the model I'm going to teach you today is one of the models that I developed to try to understand what oxygen's doing in our body, why it's important, and why it's clinically important. And it turns out when I came back 5 years ago, it's a great model for our residents as well, and it's the model I teach you guys, and I think it's a really good working model. So the whole thing is the first principle of sedation, of anesthesia, basically of medicine, is thou shalt deliver oxygen to the alveoli and then get it to the cells, right? And it's really easy. You see it when we're intubating, if any of you have seen us intubate, to focus on the procedure, right? To put the tube in the hole, and we're struggling, and we forget that while we're intubating, who's delivering oxygen to the alveoli? Nobody, right? And so that's one of the hardest things that we do, is keep in mind that it's not about completion of the procedure, it's about completing the procedure in the context of getting oxygen to the alveoli and making sure the patient doesn't arrest, right? And we have a saying in anesthesia that people don't die because we can't intubate them. They die because we fail to stop trying to intubate them. And so we get focused on completion of procedure instead of the bigger picture of, hey, we've got to get oxygen to these alveoli and make sure we have a healthy patient on the other side. And that's the essence of the tension in the GI lab too, right? Physicians are focused on, like, I got to get this procedure done. And you're focused on, I've got to keep a patient that's breathing with an open airway and sedate him at the same time. And frankly, that's the most difficult trick in any kind of sedation and anesthesia, is to get that balance safe and get that balance right. So first principle is we're an oxygen delivery service. The objectives of the lecture are to understand the priority of oxygen delivery in anesthesia and sedation. We want to understand what oxygen reserves are and where they are. And we want to understand the sequence of monitoring changes when we have an apneic patient. Because apnea is when nobody's delivering oxygen to the alveoli. And so we want to understand what's happening in each of those tanks or oxygen reserves, and then how they show up on our monitors. And we'll talk a little bit about ATP, which is, in the end, that's what it's all about. So, priorities for human survival, Maslow's hierarchy of needs. At the top is Mozart playing and writing piano concertos and concerts, right? And then he can't do that unless he has his food, water, and shelter needs met. And so we all can say food, water, and shelter. If you're a Boy Scout, that's drilled into you. First thing you do when you're lost or having troubles is food, water, and shelter. How long can you live without shelter if you're a Syrian refugee in Greece? Like indefinitely, right? You got your food and water met, and you will probably on the whole live a shorter life, and it will be an uncomfortable life, but it's not going to end your life. Water, or food, we can survive about 21 days. That's about when 21 to 28 days is when we force feed prisoners in Guantanamo Bay. And that's because they're running out of fuel. They're running out of food in their body. And water, about 5 to 7 days, we can move water from our skin put it into our vascular system, and continue to support cardiac output in carrying oxygen to cells. How long can we survive without oxygen? I like to say 3 to 5 minutes, and that's probably about right. It's going to be some sort of bell curve, but we want to err to the side of never hurting anybody. And so 3 minutes is kind of what I teach. It's probably more like 5 to 8, something like that. But if you use 3 minutes as a rule, you'll stay out of trouble. So that means we can have an apneic patient for about 3 minutes, 3 to 5 minutes, and then really bad stuff starts happening, right? 70% of what I get sued for as an anesthesiologist is airway problems, failure to deliver oxygen to the alveoli. My circuit becomes disconnected, nobody's ventilating the patient. The patient obstructs, nobody recognizes it, nobody's ventilating the patient. No oxygen is getting to the alveoli. I would bet that most of the problems in the GI lab are simply somebody is apneic, we don't recognize it or we can't fix it, their saturation drops, and then they have a cardiac arrest, right? And that's you guys are not having people suddenly have heart failure during the procedures. It's all, or most of it, is pulmonary. So basic necessities for human life, we can add on the bottom of Maslow's hierarchy of needs, oxygen, right? It is so ubiquitous, and we are so good at delivering it that we don't even list it. Okay? Are you guys all pretty good at breathing? Yeah, we can have this whole lecture, and unless I remind you, you won't even know you're breathing. It's all happening innately. Anybody have a 3-minute disruption in their life that they know of, a 3 to 5 minute where you didn't breathe? Probably not, or you wouldn't be sitting here at this lecture. Okay? And how about your mom before she had you? 3 to 5 minute disruption? Nope. How about her mom? Nope, or we wouldn't be sitting here. So, whenever we're caring for a patient, I want you guys to imagine all of their lineage that we're caring for as well, because they have worked hard. That stream of life has worked really hard to get that person in front of you. And there's never been more than a 3 to 5 minute disruption in any, back, wherever you think life began. There's been continuous oxygen delivery to those cells. And that's what's different about our services than any of the other services in the hospital. Anesthesia and sedation take perfectly healthy people with no oxygen delivery problems, no oxygen delivery problems in their lineage, and we give them potentially an oxygen delivery problem, and we have to fix it in 3 to 5 minutes. We have to recognize it, and then we have to have the skills to fix it. And those are really the things that make our services completely different. That's why all of you are super, I'm sure you're all super anal about having everything prepared and making sure your workstation is, you got your suction ready and all of that, because innately, you got 3 to 5 minutes to fix things. If the oral airway isn't out and sitting there, and you can't put pressure on your bag mask, bad things happen. And things tend to unwind very quickly as a crisis goes up. The crisis level goes up, our heart rates go up, our fine motor skills and IQ go down. And that is a recipe for disaster. So, what does oxygen do in the body? Where is oxygen consumed? Anybody can shout it out. We breathe it in. Cells, right? It's consumed in the cells. And and specifically in the mitochondria, right? And this is about as technical as we're going to get. So it's consumed in the mitochondria, and what do mitochondria make? Energy, ATP, a very specific form of energy, right? So can anybody, this is a high fidelity model. I have a real beef with high fidelity models. I learned something like this in med school. You guys may have learned the Krebs cycle. Yeah, anybody want to come up and draw it on the board? Anybody want to draw it on the board during a crisis? Right? It's not a very good clinical model. I don't use it. I can repeat it. I certainly couldn't tell you what's happening in it anymore. And so we can move to a medium fidelity model, and this is, I can probably give a lecture on this. Krebs cycle's there, oxygen goes in, ATP comes out. But certainly I'm not going to recall that during a crisis. So we need an actionable model that we can think in a crisis, what are we doing? And so let's think about this. What's going into the cell? Oxygen, glucose, which is a fuel, and what's coming out of the cell? Heat. Everybody feel warm this morning? If you've got a coat on, you're heating up your coat. And heat goes in or comes out. ATP comes out, so it's a stored and transformed form of energy that your cells can actually use to function. ATP is what keeps your smooth muscle cells contracted so that you can keep your blood pressure up. It's what is used with your heart cells so that they can contract and they can keep their chronicity or the heart rate up. Okay, and then we produce CO2, right? We measure that with our monitor, and that's how we tell that the patient's airway's opened. And we produce a little bit of water. Does that sound familiar to anybody? Has anybody roasted marshmallows over that? So a much less fidelity model, and if you press, make sure I'm not standing under a sprinkler, you know, it's a flame. Oxygen goes in, fuel, CO2, heat, and ATP come out. It's a flame. And so really the model I teach, and I teach my residents, and I teach you guys, and this is what I use every day, is that it's simply combustion. If you press a physiologist, and I've pressed physiologists on this, it's a really, you know, they do a great job at explaining it and defining it in a high fidelity model, but ultimately we have a whole bunch of cells in our body with tiny, tiny candle flames in them. And so when I put people to sleep, I actually see their bodies, you know, in my head as on fire, right? And it seems simple, and it is simple, but it's an actionable model, okay? So what do we need to have a fire? Continuous fuel, glucose, but we got about 21 to 28 days of that in our body, right? I don't check the glucose level unless somebody has trouble controlling their glucose. But I don't check the glucose level. I just assume that they've got 28 days worth in their body, and that's going to outlast my anesthetic. Oxygen, and that's what we're really going to dig into, is we've got about 3 minutes of oxygen, 3 to 5 minutes of oxygen in our body to feed that flame. And once that oxygen is gone, the flame starts to dwindle. And then as soon as the flame dwindles, ATP starts to go down. Right? There's not enough produced. How many seconds of ATP or minutes of ATP do we have stored in our body? And I've pressed a physiologist on this too. It's about a half a second. So it is produced in the cell, in the mitochondria, and it immediately meets the demands of that cell. It is not transferred around your body. It simply goes from the mitochondria to whatever organella needs it. Okay? And as soon as the production goes down, then that organella half a second later starts to have dysfunction. And then we need an ignition source. That's probably a theologic lecture because we don't know what started the spark of life, but it got started a long time ago. All right. So this is a good low fidelity model that I use and I encourage my residents to use. And this is the first lecture they get, and for the first 3 months they work with me, all we talk about is oxygen delivery and what's happening, the very model, so that it is, I believe in beating dead horses. So once you understand that, the Gospel of Anesthesia is thou shalt ensure the continuous oxygen delivery of oxygen to the mitochondria of the patient. Okay? And that is chapter 1, verse 1 of the Gospel of Sean, and it's not a very long book. What's the most common cause of death in sedation and anesthesia? Not a trick question. Apnea. Lack of oxygen delivered to the alveoli. That's the root cause. So that can come in the form of apnea, unrecognized apnea, obstruction, drug overdose, right? Has anybody overdosed somebody with opiates and propofol? Caused them to be apneic? I have. Disconnects, that plagues us, like our circuit falls off or it becomes disconnected here and we don't recognize it. And aspiration, right? You can aspirate to the point where you can't get oxygen. You've displaced all of the alveoli are filled with cheeseburgers instead of oxygen. Okay, so failure to deliver oxygen is the big thing. And this is the second part of the model. Whenever I have somebody that's apneic, I ask my residents to imagine. Now, I used to be able to light a candle here. So that's the cell. And we'll just put the lighter in there without it being on. You can imagine there's a flame burning in there. Right? And then whenever the patient's apneic, what happens if I put a bell jar over a candle flame? It goes out. First, it stays lit for a while because there's some oxygen stores in the bell jar. And then as that oxygen gets consumed, then it dwindles, right? And then it goes out. Once it goes out, we cannot resuscitate it. Right? I'm not Dr. Frankenstein. We can't shock people back to life. All we can do is try to get to that flame before it goes out because we cannot reignite it. Resuscitation is all about taking a dwindling flame and getting this bell jar lifted and getting oxygen back to the flame, back to the cell so the cell can continue to function and hopefully it's not terribly damaged. Okay? So now we're going to talk about where do we store oxygen in our body? Right? And so everybody take a big breath in. And then hold your breath for just 10 seconds. And I just want you to think about where those oxygen molecules came from and where they're going. And they're going out to your finger. There's a little flame in your finger, and we'll just concentrate on that. So everybody breathe. Okay? So we store oxygen in our chest, right? And I just breathe a bunch of air in. And so we have tank 1 is our chest tank. And we're going to remove this now and turn it into our chest tank. So it's not very complicated. It's just a volume, and it's got something in it, and in this case, it's got air in it, right? And then we have a second tank before it gets there, and that's our blood tank. Okay, again, it's just a volume. From a working model, all you need to know is it's a volume of oxygen, and it's stored in the blood, okay? And we'll talk about what happens in these tanks as people get sick. And so when I take a big breath in air, how full is this tank of oxygen? What's in there? What's in air? Nitrogen. About 81% nitrogen, or 79% nitrogen, sorry. You could do the math. About 79% nitrogen and 21% air, or oxygen. Okay? So why in the world are we walking around with a tank that's only 21% full? Can we modify that? How do we modify that first tank? Supplemental oxygen, right? So you see us, when we put people to sleep, we seal a mask on the face, and we have people breathe 100% oxygen, and we're pre-oxygenating the patient, right? And so every time they breathe out, the nitrogen leaves, and more oxygen goes in, and we can actually, all we're doing is topping this tank off, so that when the patient becomes apneic, we have more oxygen molecules in this tank to help us. That gives us a little bit of time that we can actually react. Does that make sense to everybody? Because that's kind of a key point. And so when we put nasal cannulas on people, this tank hovers maybe around 30% at 2 liters. You might be able to get it up to 35. And then we use a non-rebreathing mask, and we might be able to get it to 45 or 50. But until we get an endotracheal tube at 100%, we can't get this tank up to above 85, 90%. Okay, we never, in the practice we have, we never get it to 100. And that's because you've got a lot of nitrogen in the fluids of your body that are constantly coming out. Okay, so what does nitrogen do in our bodies? Anybody read the chapter on nitrogen, the importance of inhaled nitrogen? Right, it is not important. We can't put it into our tissue. We are not peanuts. We can't fix it out of the air. Okay, so the nitrogen we eat is what's important. So we can get rid of that nitrogen, get extra oxygen in that tank, and everything's going to be fine for the periods of time that we're working on the patient. Okay, how about the blood tank? How do we measure the blood tank as far as how full it is? Pulse ox, right? And so that's going to be a really important distinction that I want to make is, can we measure this tank? Do you guys measure this tank at all when you're working? No? And most of the reserves are here, not here. So unless we're aware of the patient being apneic, we don't know we don't know how full this tank is. And when they're apneic, what tank empties first? right? This one does, because this one empties into this one. This one stays at 98 or 100%. So if we're apneic and we're only listening to the pulse ox, now does everybody have CO2 monitoring where we are? Good. And now you can understand why. Because the CO2 doesn't tell us how full this tank is, but it tells us we're filling this tank still. Right? So when the CO2 stops, there's a big cover on top of this tank. It no longer fills with oxygen. Tank 1 sits on top of tank 2. Eventually this tank empties, and then we start to see the pulse ox decline. So one of the dangers, if we don't understand what we're monitoring, and I can tell you this is not something that's confined to sedation and anesthesia. If we don't understand what the pulse ox is monitoring, and that's how we're monitoring for apnea, we can have 2 minutes of apnea before we realize that that's the problem. And what's the most common root cause of people having an arrest or having complications with sedation? Apnea. Right? So the pulse ox somehow got the voice, and that's what we can monitor passively. But the CO2 monitor is what's really telling us the problem just occurred. And it doesn't have a voice. We have to visually monitor it. And this is where EPIC can be dangerous, right? Charting can be dangerous. Going around and assisting somebody and setting up or dealing with equipment can be dangerous. And this is why we've divided sedation from operations and procedures in the room so that we can constantly monitor and ask our patients. I ask my residents to ask themselves every 15 seconds, who's delivering oxygen to this patient's alveoli now? Is it me or is it the patient? And have we changed responsibilities? Because when that responsibility changes over, if the patient can't do it themselves, that's where we get into troubles, especially if we don't recognize it. Okay? So this tank is hanging out at about 98% full, 100% full. When we do 100% oxygen, this one almost always goes up to 100%. Okay? And so that's a big confusion point of when we pre-oxygenate people, their saturation. If you ever hear anybody say, well, their saturation's already 100%, why are we doing this? It's because they don't actually know that this tank exists. This tank only exists in your head, and it just empties out from 100% or 60% down. So I encourage people to not just do it with nasal cannula, because you've just got a little bit of extra reserves there. Why not use a non-rebreathing mask? And I don't know what the practice is, but the more the better. Like, oxygen's good, and the more of it around the face so that it's in the lungs, the better, because it has. I'm getting older. My glasses mean that my eyes don't work as well. I certainly can't think as fast, and I can't react as fast. And so I want the longest period of time to react to a problem as I can get. I'm very humble. I don't like to do things quickly. All right, does that make sense to anybody or everybody? And does anybody have any questions about that? All right, so I just want to have everybody take a breath in again and really think you just filled up that tank, and as you breathe in, you actually expanded that tank. And then if you hold your breath, you can see that tank in your chest emptying, and eventually the tank in your blood will empty, and we'll pick that up on the pulse oximeter. And I think we talked about how the tanks fill. So now we're going to do the walk of death, and this is patented by me. And we're going to think about what's happening in each tank as we become apneic. All right, so we said we've got about 3 minutes of luxury time where we've got 3 minutes of oxygen reserve, and that's, to be safe, we'll make it 3 minutes. It might be 5 minutes, it might be 8, but I wouldn't bank on it. And so we've got 3 minutes of oxygen reserve, and we're going to change some distance into time. So I'm going to kind of start. We can't do a floor model. This is a patient with a full oxygen. Both tanks are as full as we can get them. And then we'll say the end of this picture down here is 3 minutes away. Okay? What's the most common reason people have troubles? Apnea. Okay, so the event is apnea. As soon as your patient's apneic, tank 1 starts to empty. Okay, and probably about 2/3 of the way, then tank 2 starts to empty. Right? And then what happens when tank 2 starts to empty? How do we keep we've got the flame going. How do we keep delivering enough oxygen molecules to the flame that we don't have troubles, right? If my saturation 75%, I'm not going to have an MI. I'm not going to infarct my brain because I can turn up my cardiac output. And so even though it's, we'll say it's 50%, if I can circulate my blood 2 times as fast, I'm going to deliver the same amount of oxygen molecules. And so initially, I can increase my cardiac output, which is heart rate times stroke volume. So when I increase my heart rate, does that consume more or less ATP? More. And how about if I increase my stroke volume, right? And my heart squeezes harder, and my blood vessels contract so that they can drive more blood to my heart. More. So we have this danger period where our oxygen consumption is going up, our heart rate is going up, and we compensate by using more oxygen and more ATP. Does that sound like a very well-designed system as far as engineering goes? Right? It's not. Actually, it's a great system because I think it's designed evolutionarily that people die very quickly. If they get to the point where, the lion's about to eat them, the rest of the family, they can just die, and the rest of the family can take off and get out of there. And you don't end up with, these lingering deaths that go on for days and days and days. So it happens very quickly, and as soon as the first oxygen molecule does not arrive to the flame, then the flame starts to dwindle, right? So initially the flame gets bigger, more ATP is produced, so that the smooth muscles can contract more and go faster, and then the flame starts to get smaller, ATP a half a second later, we have cellular dysfunction. And this is where, I don't know if anybody's seen it, but suddenly you have a patient that has a heart rate of 160, their blood pressure's, hanging out at 90, and then they get bradycardic and hypotensive. And everybody's like, oh my God, how did that happen so fast? Now you know. They reach the point where they can't compensate with cardiac output, and then everything falls apart, and you have a cardiac arrest. And it happens fast. Has anybody been in the ED or seen that in an ICU? There's 1, 2, and that is exactly what's happening, okay? And that is happening someplace around here, and then we have our cardiac arrest. So we have 3 minutes, and I want to think about what monitor is changing when now. So initially, we're apneic. And so what's the first monitor to change when we're apneic? Our end-tidal CO2, right? And I would encourage all of you guys to not trust your end-tidal CO2. Watch your patients, and I know it's hard in the GI lab because there's a lot of things going on, but watch. All the signs that people are breathing, end-tidal CO2 is great, but it is just one way to monitor breathing. Snoring, I love patients that snore because that tells me that oxygen, or the patient is breathing in oxygen and nitrogen, hopefully a lot of oxygen, and it's getting into their alveoli. It's when the snoring stops, that's when everybody should be, thinking. Okay, so it is a cardiovascular monitor, and I believe in beating dead horses, so we'll ask that again and again. What 3 things does the pulse ox tell us? Okay, so heart rate, oxygen stores, right? How full that tank is, and what's the third thing? What's the waveform? Right, we call it the waveform. Perfusion, okay. And what organ is causing that waveform? The heart. And what's the heart doing? Expelling blood, right? And every time the left ventricle beats, it shoots out a volume of blood, and we call that stroke volume. And so actually what you're seeing there is stroke volume. So you can see, if you notice when people have dysrhythmias, you'll see sometimes it's big and then sometimes it's small. And that's because the preload is changing and you're getting different stroke volumes out. So when the pulse oximeter sound goes away and the thing goes flat, are you guys alarmed? And why are you alarmed? Yeah, because the cardiac output just disappeared. Now it could be a cuff going up with this here, but if the cardiac output just disappeared, the patient may be in cardiac arrest and you need to do something about that. So is the pulse oximeter a cardiovascular monitor or a pulmonary monitor? And we'll do it one more time just so that you guys can review. Okay, so we did the walk of death. Key points is oxygen delivery takes priority over completion of the procedure and everything else. right? We have not won the game, and we've not done our patients any service if they have apnea and a cardiac arrest. And it all happens very quickly. Oxygen is stored in our body. We have about 3 to 5 minutes of oxygen stored on in our body in a good day. And it's stored in the chest and the blood. And please just think of those as tanks. Or you can think of it as battery bars, I guess, for the millennials out there. But water tanks, whatever you want. And we're trying to get those tanks as full as possible in case the patient becomes apneic. Okay? Failure to deliver oxygen to the lungs leads quickly and predictably to the depletion of oxygen in the body, resulting in cell death. Right? What's the first cells to die in the human body when they don't get oxygen? The brain. Second is cardiac. Okay? The kidneys and the liver can go quite some time without oxygen, but you can quickly get brain death. Anesthesiologists are always sad when they have a patient that's apneic for 5-8 minutes and they think, oh, I got away with it, or I fixed it, but it was really close, and then they wake up and they've got brain damage. So it's very quickly, the brain cells are very sensitive and they die very quickly. And so don't make apneic patients. Okay? And then monitoring can detect physiologic changes before they become physiologic harm. And the further ahead we can see that change, the better for our patients and the better for us. Okay? And so end-tidal CO2 is the current monitor we use to tell us whether we're filling that first tank. It tells us nothing about how full that tank is. Right? We have a monitor in anesthesia called the end-tidal O2, and that'll actually give us some readings about how full that first tank is. Most anesthesiologists don't use it that way. Okay? And then if we just monitor with our SpO2, we don't know what's going on until we get here. And then I hope you guys can respond and get somebody, oxygen back to their alveoli in 45 seconds or a minute. It's difficult for me to move that fast anymore. Okay, does that make sense to everybody? Okay, so next thing I want to do, I'll switch these back around. I want to think about which patients are really dangerous to sedate, right? If failure to deliver oxygen to alveoli and cardiac arrest is what we're worried about, then we're worried about the patients that have a really short walk of death, right? Where you're starting here or here, right? And you can't fill up those tanks. And really the way to think about that is they either have very low cardiac reserve, so they can't increase their cardiac output when they get way down that walk of death, or they have something else in their first tank instead of oxygen, right? So what if a patient has a pneumothorax and one of their lungs doesn't exist as far as volume? This tank's half as big, so we're going to actually start right here. What if it's full of pus instead of oxygen? What do we call that? Pneumonia, right? What if it's full of pus instead of oxygen? How big is that first tank? Right, we can get it 100% full, but we're starting maybe here. How about if it's got a whole bunch of water in it? What do we call water in the lungs? Pulmonary edema, right? And so patients with pulmonary edema are here. What if they're super atelectatic, where those little balloons are collapsed? They're starting here. How about if they're morbidly obese? Right, this tank's going to be tiny, tiny. Right? And those are patients that desaturate very quickly. You don't have that 2-minute. Those patients actually die really quickly. What if somebody's got aortic stenosis? Can they increase their cardiac output? No. And so as soon as they start to desaturate, the flame starts to drop because they don't have any compensatory mechanism. How about right heart failure? Right? Bad. How about left heart failure? Mitral regurg. So we want to look for patients that have cardiac problems, undetected cardiac problems. And then this is why, I encourage all of you guys, if you're ever uncomfortable that, this patient's, just dicey, just call us, we'll come down, and we're always happy to come down and take a look at the patient. But you now have a model that you can explain to your physician why you're concerned, right? That patient, instead of having oxygen in their alveoli, they've got a bunch of pus. That's problematic. This patient is morbidly obese with a beard, so I'm afraid that they can't store enough oxygen in the chest, and then they've got a beard, and it's going to be very difficult to get a mask on them and actually ventilate them if they become apneic. This is a high-risk patient. So you can use this model to assess the risk of your patient, because really what you're assessing is, do I have enough time to respond, and then do I have the skills to respond? Because if you don't have the skills, and airway management is a high-skill event, if you don't have the skills, then that doesn't help your patient either, and you can quickly get out there on a limb and end up in cardiac arrest. Okay. Does that make sense to everybody? Yeah. Okay. How about an anemic patient? Let's talk about this one. How about an anemic patient? They don't have as many hemoglobin molecules. Is this tank bigger or smaller? Smaller. How about a patient who's volume depleted? Smaller. Right? Somebody who's got an upper GI bleed. Right? Very small. And so again, your walk of death is going to be just a couple steps, right? And then you're over the cliff. Trying to think of other things that would affect this tank. Those are the two main ones that I think we'll talk about. Yes, I would. Because when you're initially pushing the drugs, that's when you can have a bout of apnea. And you might as well be here rather than there. And it doesn't take much to put a mask on just before you push the first drugs.
Does it matter how long?
Yeah, you want to do somewhere between 3 to 5 deep breaths, probably about a minute. And I usually, if you guys have worked with me, I usually have people take your big breath, blow it out like birthday candles, and I do that 3 times. And all I'm doing is quickly topping off that tank, so if I do have a problem initially, I can deal with it. And then oxygen always during sedation, because that way you're just riding into battle with a full tank of gas. Who wants to go into battle with their tank only 21% full? There was one here that I...
Yeah, can we talk a little bit about COPD? I tend to think COPD patients are 10 times worse than the apnea patients. I'm sedated at a time.
Right, so yeah, the paradox of COPD patients, depending on why they have it, is that this tank is actually smaller even though they have bigger volume, because their alveoli are blown out, so they have less surface area, and that concept is tricky for people. But COPD patients tend to desaturate very quickly. Often they have right heart failure, and so you've got a small tank combined with the inability to increase cardiac output, and those are patients with a very short walk to the grave. And so those are patients that I'm concerned about them. Okay, not alarmed about them because I understand what's happening, but I'm concerned, and then I think, all right, what can I do to minimize that risk? And then do I have the skills to actually care for that patient? And that's we try to do ASA 1, ASA 2, ASA 3, but those are, and I think we do a really good job actually at risk stratifying. But and I'd say if you're concerned, then just express your concerns.
Should we be doing those patients in the clinic?
Well, I don't have the answer for that, because it depends if the resources are available to take care of them. One of the things I'm faced with every day is there's cases that make me nervous, but they do fine. And so part of it is I may be concerned and nervous about the case, but I have the resources to do the best job, and they're in the right spot. But I'm in a tertiary care operating room. If it isn't available there, it's not available anywhere. And we're very highly skilled, and we have long training periods to deal with those things. And that's frankly the hardest thing, is understanding whether what we're doing is safe. And I really believe we have a very good quality assurance system here at the University of Utah, and we're very thoughtful about what we're doing. But if you're uncomfortable, speak up. But sometimes it's okay to be uncomfortable, as long as you come to a consensus decision about whether it's safe to do it here. And so